Hello and welcome to the Data Slayer podcast, where insight meets impact, brought to you by the team at Blue.Point Supply Chain Solutions. Blue.Point is a data intelligence platform with a focus on clinical product utilization. And in today's episode, we are going to discuss how to initialize the transformation of your value analysis program or process. And if you're new to our podcast, our first 3 episodes explained our platform and how data and value analysis all work together, which perfectly leads up to the subject we will be discussing today with real-world examples. I'm your host, Jennifer Doty, and joining me from Blue.Point are Anne-Marie Orlando, the Vice President of Clinical Services, and Keegan Smith, the Senior Manager of Analytics and Product Development. And we are fortunate enough to also have 2 special guests joining us. We have Michael Cordi and Ty Yilmaz, both from Sturdy Health, an independent nonprofit community health system based in Attleboro, Mass. Welcome, guys. Nice to have
Thanks
you
for having
here.
us.
Thank you for having us.
Yeah, so Michael, I'll start with you, if you wouldn't mind sharing a brief introduction of yourself, your role, and how long you've been in this role.
So my name is Michael Cordi. I'm the Director of Supply Chain at Sturdy Health. I've been at Sturdy just over a year, but I've been in healthcare supply chain, believe it or not, since 2002. Started my career at Bay State Health, which is level 1 teaching hospital out in Western Massachusetts. I spent the better part of my career there doing various roles within the supply chain. Started off with warehousing, logistics, moved into inventory control. Actually spent 4.5 years in a heart and vascular OR, so I got a little bit of a clinical background there. Then I moved into procurement. I was a lab buyer at one point, and then I moved into a value analysis coordinator. And then from there, I went into capital procurement so all hospital building projects. So I've been exposed to a lot. I left Bay State back in 2021 and went into healthcare consulting. I worked for an advisory firm that gave me the opportunity to travel all across the United States, helping large and small size health systems make their supply chains more efficient. And like I said, I landed at Sturdy about a year ago. Now I'm in the director of supply chain role.
Awesome. Well, thank you for joining us. All right, Ty, I'll have you also introduce yourself for us.
Thank you, Jennifer. My name is Ty Yilmaz. I am the business manager for the perioperative services division here at Sturdy Health. I've been in this position for about a year and 4 months. My background is in various clinical settings, academic medicine, and surgical services. In my role here at Sturdy, I oversee the perioperative business operations, charge capture, and perioperative specific materials management. I've spent about 2 years more recently as a program administrator in the academic side with Brown Urology. And before that, I was in ophthalmology operations, where I worked on workflow optimization, revenue cycle improvement, and various care access initiatives. I also come from a little bit of a clinical background. I was an ophthalmic photographer, which is an allied nurse type of professional. I've also been in clinical research, so most of my 20s was involved with publishing various forms of clinical research papers. And over time, I sort of navigated into healthcare administration, and very eager to continue my learning of supply chain management, and couldn't be more grateful to have Mike in the partnership.
Well, based between the both of you, we have a lot of experience here today, so this is going to be a great conversation. So I guess to start with our first topic, I did want to talk about, or have us all discuss, what processes did you bring or learn to enhance at Sturdy Health within the value analysis as we see it today? So
I can start if you want.
Okay.
So, when I got here, it was really kind of everybody doing something in a silo, right? There wasn't really any governance around the VA policy or structure or even, the meetings themselves. So kind of first order of business that I did was I rewrote the policy, right? So from scratch. It was actually an iteration of multiple policies that I've, curated over the years, but we brought it here to Sturdy, and, with the help of Ty and other nursing leadership and clinical leadership, we really tried to revise it to fit Sturdy's culture at this point. Obviously, it was a very comprehensive policy, and it was made to align with best practices. And what I tried to instill was, this is out of a maturity model scale, this is a 5. What is written is a 5. It doesn't mean that we're there right now, but this is what we need to strive towards. But to have it kind of laid out, we can at least work from that, right?
Yeah.
So we created a new policy, and then part of that was a charter, a 1 to 2 page charter that really is a truncated version of that policy with highlights of, meeting cadences, prep meetings, and outlining that. And then kind of, just additional supporting documents. So we had to actually look at our roster, right? Because we kind of had this broader committee, right? With just like a million different stakeholders that didn't really belong. So what we did was we created 2 subcommittees, one for peri-op because, kind of ties the area, and the one for nursing, lab, and then other ancillary support like respiratory and things like that. So we broke it out, broke down this huge, large committee where there was way too many stakeholders. They didn't really even need to be there. We created new rosters and new subcommittees, and then we created an executive committee as well because we put some thresholds into our policy. If it reaches X number of dollars as, for an approval process, that will be an operational increase. We need further approval. So, most of that is done and written and approved. We're still working out some of the kinks. We created a new product request form. We don't have a software system. We're working on trying to get one of those to help us stay more centralized with our data. But current state is, we have an electronic form that kind of, that folks can submit, and then that drives the agenda. So, we're working on all, reaching best practice. Software would enhance that. We're not quite there yet. So we're doing some things manually. But I think to go back to the original question, we really went back to the policy, the charter, and the people, and really took a deeper dive into that and revised that. So that was really step 1.
Yeah,
That's
I
great.
Mike framed that really beautifully, and he's right. There was a lot of legwork that once Mike joined on board, which was shortly after I was here, there was a lot of what I would say revival. Whatever existed prior to our time was sort of in a quiescent state at best. And I think being able to tap into Mike's, multiple years of experience really helped kind of put a lot of meat on the skeleton of what was here. So, he certainly spoke to the idea of the maturity model that we have with our value analysis committee, and certainly we are on a trajectory. And I think having that policy charter, the right people in the right room at the right time, that's been really wonderful to really help have that framed out. I think one thing I'll add on top of that is the conversations are also happening. I think, certainly Mike is leading one aspect of the value analysis committee for the hospital system. He works in tandem with me to, sort of as a mentor within the perioperative space as well. And I think both separately but in concert, we've really emphasized the importance, I think, on difficult conversations, because for folks in our roles, I think value analysis, it's intuitive, it makes sense, it's part of our experiences, but we also have to meet people where they are and also realize that that's not they're not living and breathing our worlds, but being able to communicate the why and the necessity behind activity like this is so important. And I think certainly we've cut our teeth quite expansively in the time that we've worked together in aligning with providers, with nurses, with surgical techs, to just have them understand like what's the underlying conceptual framework behind value analysis as a tool just for financial sustainability, but also making sure that we're all working towards that similar end of putting the patient at the end of all of the activities that we're engaged in. And I think when we're framing it in that way, it's less an exercise of, well, you know what, the business manager is just saying we need to do this, and the head of supply chain is saying this is a necessity.
Yeah, because when you're new to an organization, like both of you were new, while you bring in all of that type of experience, right? People are often thinking, oh my gosh, what are they changing? What are they going to make us do now? And so sometimes you hit that wall of, no, this is how we do it. And so getting them to embrace all of the changes, which are for the better, right? It can be a daunting task. So kudos to both of you for spearheading that and engaging with those stakeholders. So,
Thanks. Thanks for the
Yeah.
recognition. Yeah, the work's not done. And I'll say
yeah,
this process is a fluid process, right? Throughout, right? This will be revised and iterated on, in a few months. And that's how it should be because things change, times change, like how we act as an organization, it's always fluid and changing. So I think, a policy is not like a law, right? It's a guideline. So,
yeah,
Mhm.
and sometimes folks will say they kind of look at it that way, and try to at least illustrate, like, no, this is guidance. This is
yeah,
not set in stone. If we have a better way, let's do it. But we need to start from somewhere, and this is the
yeah.
starting point. So,
Yeah, absolutely. And just to make one last additive comment there, I think, I see both Mike and my role, and certainly for anybody who's engaged in the value analysis process, is sort of a steward, right? That, whatever gets brought into any hospital system or really any system that delivers some element of healthcare, that those items belong there for a reason, that there's not just the cost element to it, but there's also a clinical value that's being brought with that. And because at the end of the day, do we want to expose our health systems needlessly to various forms of financial exposure and not have a just cause? I don't think anybody would agree to that. And I think it's incumbent upon anybody involved in the value analysis process to be able to rest on those pillars of the financial stewardship, the clinical justification, and if you can marry that towards the ultimate end with the patient there, then I think you've done your job. And certainly to Mike's point, this is an iterative process. We have to look at it as an ongoing journey, and it involves multiple elements of conversations. It's not just Mike and his supply chain team, or me and my role saying this is just what has to happen, but really engaging stakeholders to make sure that they feel like they have a voice in the matter, and us bringing that clarity to all of this.
So part of that, have you provided, those that are now sitting at the table and you're inviting them to have that lens, right? That, is it a people product, are the products that we're bringing in, is it to address a problem or is it just an ask, right? Are we, before we even brought in a product, have we looked at the process? Have we looked at the people, right? Before we address that? And have you done any education with those stakeholders to help them see the lens that they should be looking at these products and these requests from?
I think that's the end goal. As we start to get more comfortable with the new process, I think that will come. I don't know
Yeah.
that we're there yet, if I'm answering that question honestly. I think the framework will allow for that, and that's the goal.
Yeah. Yeah.
I think for us, it's getting it off the ground, kind of basically starting from scratch. Like, all right, make sure the product request form's filled out completely, right? So if we have all the information that we're asking,
Yeah.
we can help answer all those questions, right?
Yeah.
So, we're in the infancy stages, but I think, we have the framework there. And as folks get more comfortable and as we have more meetings and the dialogue starts to, become more robust, yeah, I think to that end, we'll start to check those boxes as well, Anne Marie.
I agree wholeheartedly. And I think, speaking to the work Mike did at the outset when he started here, he spoke about getting a proper VAC roster. And I think some people may view that as just a list of names. And I think it goes far, far more than that. And the reason for that is understanding, why is this person in this room? What opinion are they bringing to the table? Why should somebody who's a financial analyst be at this conversation? What about somebody who's an infection disease risk nurse? What about
Yeah.
X type of provider? And all these things, again, obvious to folks who are in value analysis, but in a committee like that where you're hearing the voices of multiple stakeholders, that's where you're going to start to see, oh, okay, I didn't realize that I can't just say I want this particular product because it impacts this coder, for example.
Yeah.
And I think that's where, the committee can help kind of provide those sparks of, okay, I'm understanding the real meaning of an organization like this.
I always think about, when you go and you represent your department in that value analysis committee, you don't realize sometimes your patients that you're seeing, what do the nurses need to understand about the post care of that new product you're asking, and or what are some of the, maybe I'm asking for something for my department, but now I'm creating two standards of care at my facility, right? So VA really helps you look at it from that, not only at the micro view, but at the macro view, and really being able to help, the organization act as an organization and treat the patients as they should, with this standardization in mind, and ensuring that we're there for the patients, but also training and education and all that other stuff that we need to make sure that we're being mindful of. So, yeah.
Yeah, I think you have all touched a little bit on the why behind value analysis and why you do what you do every day. I don't know if anyone wants to expand a little bit more on that, on the importance of this for those who might not understand.
I mean, I could add a little bit more. I mean, I think you need, so anything supply chain is really process driven, right? So I think in order to be successful, you need a system or a process in place, right? So I think value analysis is not only a governance structure, but it's a process that, if we adhere to, it's something we can lean on. It's not just, we don't want it to be just a yes committee or a no committee, right? We want it to have some depth, right? So like, for example, if a provider says, well, I want this new widget and it's going to save 35 minutes of OR time. Okay, that's great. But are we measuring that, right? It's one thing to say it, and it's another thing to actually, go through the process, do the look back. So, that we wanted to ensure that that was part of, our process, right? Is to ensure that, really we're hitting on multiple pillars when you build a VAC committee, right? It's not just new product requests, right? It's also the look back. It's also sourcing initiatives, partnering with our GPO. The why, yeah, it is financial stewardship, but to Anne Marie's point, Ty's point, what is the clinical impact, right? If you have two widgets that already do the same thing, that may be a different clinical nursing practice. We need to be able to recognize that and socialize that at those meetings so people understand. It's not meant to be a barrier, and so that's also something we're trying to illustrate. It's meant to be a conduit, and I think with change and new things, people are resistant to that. So it's good. It's how you socialize it. It's how you roll it out. It's how you implement it is key in this process. So I think, to answer your question around the why, it's to have something comprehensive that's systematic and valuable.
So I have a question for you guys. While you're moving through the VA process and working with your stakeholders, I come from that. You got to tell the story and you got to have stuff to back it up, right? So the data. So what important data points do you guys focus on? Do you use, scorecards, dashboards? What is it that you're constantly looking at? Like, what's that metric being used mainly in your process?
I mean, from a supply chain perspective, we look heavily on the financial. We partner with our GPO, right? So that's the huge part of this. A majority of our supplies are contracted through a GPO, whether it's a national GPO or a regional. So we try to align with them. And I think product categorizations, category management, if you will, is a big part of that on the supply chain end. So looking at financial impact. So we use a lot of our purchase order data. We also leverage some of our GPOs, spend dashboards, category management, and then also our new product request form drives the process as well, right? So we're asking for CPT codes, right? DRGs, right? If those are there, and it's how we present it. So we basically have a 2-slide process um, for each request. So the first slide is the clinical. So it kind of addresses all the clinical questions, CPTs, all the different data points that go there, reimbursement, et cetera. And the second slide is the financial, right? So if you're going to go from widget A to widget B, what does that look like from an operational impact? And then hopefully, with our decision support team, some people call that differently, but I call it decision support. They're looking at that cost of care, right? Like, is this case profitable? What are the direct costs? What are the indirect costs? And if we were to add this, what does that look like, right? So I think we're pulling multiple data points, right? So it can be, from revenue cycle to implant record utilization to PO data to category management data off of our GPO. So we're pulling in multiple data points. And I think that's why I would love a value analysis system that can integrate all those things into it. Right now we're doing it manually, but we are capturing all those different data points.
Good.
Awesome. How do you guys define a project as being successful, right? With that data and those data points, like what metrics hit it off as being a successful project, but then where do you see some potential gaps that you're going to continue growing on because you guys, are just starting?
Yeah, I'll answer then go to Ty because I think we have different needs. So for me, I have a supply chain savings goal, right? So my goal is to drive that. And obviously, we funnel a lot of our, conversion standardization initiatives through the VA, right? Because we need clinical buy-in to do this. So for me, it's measuring cost savings. So looking back year over year. So we said, we brought this to VA. We said we're going to switch from this to this, and we're going to save this. So it's doing that look back over the course of the year, and I would call it realized savings, right? Did we actually realize what we said we were going to do? And hopefully, with that, the clinical piece of it, we brought in a product that was, we standardized. So on the nursing practice end, they're dealing with one item to do this type of clinical practice. So we've hopefully lessened the burden on all the things that they have to know. And hopefully that translates into better outcomes because it's one less task, or it's one less product that may be the same. That why am I doing this differently if it does the same thing? And then realizing our financial savings targets at the end of the year. And I'll kind of pass it to Ty. I don't know if it's different clinically. I'm guessing there's a little bit different.
Yeah, well, you articulated that really well, Mike. I agree with a lot of it. I think certainly in the world we're in with peri-op, we see a lot that does dovetail with what you just spoke about. I think sort of from that boots on the ground perspective, you hear a lot from the nursing staff and the techs and materials coordinators of, the impact of switching from one thing to the next. So it's a little bit of a qualitative measure, but I certainly, the less I hear in annoyance is one element that is a good tracker for me. But in terms of the more quantitative piece, I think, and to what Mike spoke to, having software to help measure a little bit more of this, we're looking at options within peri-op to help us with this as well. But one piece that I'm hoping for is just being able to use the surgeon preference cards to understand a little bit more of our cost variance. Right now, we're not ideally where we need to be in understanding those differentials, but those can be utilized as a tool for conversation with providers. And I think, it helps bridge communication gaps when we're trying to just educate our providers on where the current state is versus where our hopeful state might be. I think also looking at our denial rates is another piece that I have found success in, just to say, we went through this with particularly our sports medicine arena, where there are a number of items that fall in the category of allografts. I think if those can be well managed and we can switch those appropriately to alternatives, it helps us with the charge capture reconciliation process, but also ensuring that there's that clinical effectiveness that goes along with it. And certainly, the overall clinical adoption and the outcomes that come from that, we always want to make sure that our patients are receiving the most cost-effective, patient-centric, high-value care possible. And a lot of that is driven by, the right choice in supplies. And, it's never a race to the bottom. And, certainly Mike and I have, added a few grays to ourselves in all sorts of
Or
negotiations we've been a part of. Um, but I think, one exercise that's coming out of that and take home point is it's not always a race to the bottom, and it's important for us to be conscious of that. But being able to standardize appropriately and realize those cost savings are going to be really important.
I think transparency there is key, right? Because a lot of times we are not as transparent with physicians, when they're performing the case, right? They're thinking about, the operations of the case, right? The supplies they have, who's standing next to them at that table, right? That is a big deal to them. And what are they putting in my hand? What do I have access to? And so they're not thinking about all those other things that help you keep the doors open and make sure that you can maintain the community health and access to healthcare and all the other operational things that go into that procedure. So transparency is great, and building the culture that is open to looking at that transparency is important too. So it sounds like you guys are well on your way
Yeah.
to that position.
Yeah, I would, like to get deeper into scorecards, as you mentioned, Keegan, and I
Yeah.
think that correlates well with, the stuff that you're doing at Blue.Point, the clinical supply utilization management. I think that's one of the pillars of VA, and I think when you're a mature health system, that's what you're looking at. That's integrated into your VA program. It's written in there right now for us
Yeah.
to start doing that. Have we done it? Not to the level that we need to. But I agree, like those are big things, not just looking at price at the pump, but clinical utilization, right? You're all doing the same case. It's all the same DRG, the patient population. I've always heard the argument, well, my patients are sicker than your patients, so I
Yeah.
have to. So I know, but we have enough data now to make all things equal, right? Which
Yeah.
is powerful. And
Yeah.
say, no, why are you using all these advanced hemostats? And this
Yeah.
provider B had the same patient, right? Same age range, same comorbidities, and they didn't use it at all, right? So, I think the data is powerful, and providers don't want to be called out, and you don't want to call them out because, they are, helping keep the lights on, right? So,
Exactly.
it's a very delicate way that you have to socialize this information.
Yeah.
And it's a little bit of an art form that I have not yet perfected, but I'm working on it.
Right.
That's what
Okay.
Kai's there
It's
for.
fluid.
Kai's there to smooth it over, before I open my big mouth and say something that I shouldn't. But,
I just wanted to add one item. So when Mike and I were convening about something earlier today, he mentioned the process improvement concept of swim lanes, and I think it's very relevant. And to that end, oftentimes you have multiple entities working on similar but distinct items that relate to value analysis. And I'll give you one example where we've had conversations around certain items that stand a pretty low chance of making it through value analysis, not because there isn't the clinical efficacy there or because the hospital doesn't want to support the provider in the product's inclusion, but the payers have very specific coverage policies that just very clearly name this is experimental and investigational. And leaning into that conversation, and you spoke to the culture of transparency. I think that's one element that maybe value analysis committees may not necessarily think of when trying to build out a larger scale program. But I believe in that, and I certainly see through the dialogue that Mike and I have had in our separate but related conversations throughout the hospital system, that being honest, being as transparent as possible of where person one who's working on one element of a product being here versus other folks along that chain, just providing as much of the 30,000-foot view of all of that, that can do so much more than an email or just, communicating just your angle. Being able to name all of that, I think has really helped us kind of help tighten our processes and help with our efficiency. Are we there yet? Absolutely not. But I think with every month that we go through and have our value analysis committees, at least on the peri-op side, I just see the tenor and the tone of our dialogues changing.
Great. It all starts with having the same goal, right? Good patient care, good high quality patient care, good outcomes. So.
Absolutely.
Well, I think we did receive a lot of good advice already from you. But is there any additional advice you would like to share with a value analysis team that's looking to mature in their process?
I would say start with your policy, right? Like I said, it is a guideline, but make it as comprehensive as possible and making sure you answer the questions that haven't been asked, right? And that happens a lot. So that's why, it was important for me. And they're like, why is your policy 15 pages? I'm like, well, I didn't want it to be that long, but like, if we're going to answer all the questions from each angle, right? Not just supply chain, but the clinical, the rev cycle, if we're going to answer all those questions, because there's odd things that happen in supply chain every day, right? And I've been
No.
fortunate to have been exposed to those, both good and bad, things that make you want to never do this again, and
Oh,
things
yeah.
that make you come back. Like today, I don't want to come back tomorrow, but because of contrast media, I don't know why it's on national allocation. I can't,
Yes.
but I have to solve for it, right? So,
Right.
I think starting at the policy, creating a robust charter, and the stakeholders. I think that's a key piece. Is finding people. There's a lot of reluctance with leadership and wanting to chair these committees, and I said, well, you're a clinician, right? You can't be. We have to have people that have clinical background, but also are far enough removed where their colleagues still respect them, but they also are going to respect your decisions. And and I think it starts there when you're kind of building your roster, writing your charter, writing your policy, being very careful about who you choose to be on that group, because nobody wants another meeting. So I think that was the other piece. So if you kind of have all these elements and you have a good process, the meetings are actually pretty efficient, right? Like if you write that in your policy, it's written right in there. If you don't show up for the meeting, we don't talk about your request. And if you don't show up again, it comes off, right? So you basically get two chances, and you have to be that granular. So I'd say be granular in your policy and setting expectations, because that helps drive the process as well. So that would be a recommendation. Be granular in answering the questions that maybe are tough, but it's all for a greater good. So you're not doing it to be the bad person. You're doing it to be efficient and create an efficient process. So I wouldn't back away from that.
Solid advice.
Yeah, I mean, I think it's difficult to move forward on anything if you don't have a policy in place, as expansive or as diminutive as it may be. So I think, you have to start somewhere. I think one thing I'll add to what Mike has said, and I'm certainly saying it from a little bit of the perspective of some bias, is I think certainly incorporating a little bit more of the revenue cycle reimbursement piece just for awareness is really important. Certainly at the national level, it's becoming that much more difficult to get paid on cases, period. So that puts the onus on a host of folks within value analysis to source products that are as cost efficient and clinically safe as possible. So again, I certainly spoke to the notion of a race to the bottom. It should never be that, but at least having an awareness that we should be very conscious of the cost input. And then I'd say, Mike also spoke to the fact that we don't have the software leverage to help guide us with these decisions. So, some of the gentle nudging and pushback I've given to providers who are bringing products forward has been, what's your clinical justification? And I say that from a place of bias as well. Most of my 20s and early 30s was pretty fairly involved with clinical research. So, I understand that sometimes based on certain clinical trial designs, you're not going to get a randomized controlled trial for everything, but
Right.
we should at least be angling towards that, because that is your highest level of evidence base. And, certainly if there's systematic reviews or meta-analyses out there as well, even better. But to say that, I'm presenting this product, there's nothing in the literature, there's no meeting abstract, then, it makes it very difficult to present this to a host of committee members who are expecting that this is somehow, something that has weight to it. But I've seen that conversation change a little bit, which is great. But that's certainly
Right.
lots of things to consider.
Yeah. And I think the landscape has changed for the folks that now support these committees. Before it was kind of a very totalitarian, the doctor gets what they want, don't question it. I said so, this is what I was trained on. And I think, when you instill a good governance and a policy, and then you actually have stakeholders that are equally engaged, that are bringing good data, right?
Yep.
It takes kind of that element out of it, right? A lot more talented people, and I'm not saying there weren't talented people in the past. It just wasn't given kind of the proper due or respect that it was in the past, and that's just been the nature of healthcare supply chain, right?
Yeah.
So
Exactly.
I think we're also in a time period where we're doing good analytics, right? We're bringing in evidence-based data into our analyses, and then we're presenting these things. So it's not just because I said so and because I'm the surgeon. So I think that also
Right.
has a lot to do with this as well. So lean on that, I guess, if I'm giving
Great.
advice.
That's why we are here.
That's
Any last
Awesome.
points, Anne Marie? Anything you'd like to add?
No, I was just gonna say, once you get that process or that policy, you definitely need to uphold it. And that's sometimes can lead to those hard conversations that you had, if they're not willing to come into, the meeting to discuss the product, well, I guess we don't need to have that product on the agenda, because really, if it's your ask, only you can really speak to what the clinical benefits are going to be for that product. I think that's just something that we need to have people be comfortable with, is having those difficult conversations, and then having, and on the other side is making sure that everyone is educated on what that expectation is. We're not here just to say yes to everything. We need to question, and it's not from a place of skepticism. It's just, we want to make sure that we're doing right by the patient. What does the IFU say? Is the IFU, 3 pages or 300 pages? Can my staff actually follow it? Right? Is it very confusing? Is it going to lead to more issues than we're trying to solve for? There's a lot to discuss there. And then site of care now is coming into play. So especially Ty, in your space, right? Are you going to be, is the hospital the best place for this? How can we wrap in your ASCs, develop that? I think that's something you guys are going through right now. So, so it's really great, but that policy is going to be, your, for lack of a better word, your Bible. and you just have to be able to, speak to that. So.
Yeah, and I think just one last thing is, I remember when our CFO came back to me because she didn't want to read it because she said it was too long. She's like, "Well, this isn't an academic medical center," and I go, "Well, you're welcome." I go, because we may not be an academic medical center, but we should be approaching, our value analysis through that same lens, right?
Absolutely.
So I took that as a backhanded compliment, but
Yes.
it was okay.
We will take all the compliments we can get, right?
Every day.
All right. Well, I think that was a really nice episode. Thank you for joining us. And thank you to everyone who was listening. We really appreciate everyone joining us today. Please, for those listening, please like and subscribe wherever you are enjoying this episode so that you'll be informed the next time we have an episode air. And for more information, you can visit our website at bluepointscs.com or any of the links in the podcast or video description. And one last thing, remember, best practice doesn't have to cost more when you slay your data with Blue.Point. Until next time.
Okay.
Bye.
Thank you.
Thanks,
Yeah,
everyone.
guys,
Thank
so
you,
much.
everybody.
Bye. Have a great day.
All right. I do go through and edit, so like this whole part right now is being recorded, but of course we're not going to
I promise
include
not
it.
to swear. Okay.
Yeah.
I'll do my best.
I could probably figure out how to add a bleep.
Just put censored right across the screen.
Yeah.